morning all. Today we will be discussing the management of low risk and intermediate risk neuroblastoma. The learning objectives of this seminar is the recap of the staging and stratification that was done in the previous session, the treatment options that are available, surgery, chemotherapy and follow-up. In coming to the introduction, this there are two staging systems, which is the INSS, International Neuroblastoma Staging System, and INRGSS, International Neuroblastoma Risk Group Staging System. The INSS is based on the upfront surgical resection, and accordingly it has been stages 1, 2A, 2B, 3, 4 and 4S. Based on preoperative imaging, which defines the image-defined risk factors, the new INRG stages are L1, L2, M and MS. Based on these staging, there is the risk stratification. Based on the INSS staging, including the pathological classification, which is this modified Shimada classification, which differentiates into favorable histology and unfavorable histology. The COG risk stratification has been done, which groups the patient into low, intermediate and high risk groups. INRGSS staging groups the patient into very low, low, intermediate and high risk stratification. Coming to the management of low risk neuroblastoma. COG group includes INSS stage 1, INSS stage 2, except more than 18 months or with positive MIC-N amplification or unfavorable histology, stage 4S with favorable histology and MIC-N non-amplified. And INRGSS includes very low risk group as MS, L1 or L2 with maturing or intermixed ganglioneuroblastoma, L1 without a MIC-N or L11 aberration. Low risk group includes L2 with nodular gene ganglioneuroblastoma or differentiating neuroblastoma. M less than 18 months, which are hyperdiploid. Coming to the management, in very low risk groups, which include small adrenal mass which are detected in infancy, less than 3 to 6 months, or antenatally, observation is only advised. In low risk group, in the first group L1, in which the patient can be of any age and MIC-N is non-amplified, surgery or only observation is advised. In infants age less than 18 months, which localize unresectable disease which are MIC non-amplified, either observation can be done if there are no life-threatening symptoms or chromosomal aberrations, otherwise chemotherapy is indicated. Surgery after chemotherapy is only considered if IVRF are negative, otherwise observation is to be continued. Infants age 12 months with INRG stage MS or INSS 4S and are MIC and non-amplified are the group which will be discussed further in detail. Coming to the management, patients with INSS 1 and asymptomatic INSS 2, surgical resection of more than 50% tumor is sufficient. 3-year overall survival in this group is survival rate in this group is approaches around 97%. If followed regularly with ultrasound or CT, is recommended quarterly during the first year and semi-annually in the second year after diagnosis. The decision are also often based on the presence of life-threatening symptoms. Life-threatening symptoms include, in cases of intraspinal neuroblastoma, in patients who have symptoms of spinal cord compression or have a spinal tumor component that occupies more than 1/3 of the spinal canal in the axial plane, including or includes the perimedullary leptomeningeal spaces or the spinal cord signal is abnormal. Coming to the systemic upset, pain requiring opiate treatment, gastrointestinal symptoms which includes vomiting, needing NG support or IV support, weight loss more than 10% of the body weight. Respiratory symptoms include distress without infection, tachypnea, need for oxygen or ventilatory support. Cardiovascular symptoms include hypertension and IVC compression, which may include leg edema. Renal symptoms would be because of the impaired renal function, increased creatinine with poor urine output, hydroureter or hydronephrosis. Hepatic dysfunction including the abnormal liver function, evidence of DIC or reduced platelets less than 5,000. Bladder bowel dysfunction secondary to a mass effect. Or a very large tumor with possible tumor rupture or the possibility of rapid development of systemic symptoms. These are described as the life-threatening symptoms. In life-threatening symptoms with low-risk disease, chemotherapy is advised. Initially, a regimen of carboplatin and etoposide is given. If the patient is non-responsive to this, cycle of cyclophosphamide, doxorubicin or vincristine can be given. Coming to perinatal neuroblastoma, these are those cases which are detected antenatally or within the first 6 months of life. They have a 4-year overall survival rate of more than 95% with observation alone. The ongoing COG study recommends close observation and serial USG for tumors. without biopsy or any surgical intervention. This study of ANB-L00 people included an arm of the expectant observation, which included infants with an adrenal mass of diagnosis at the age of less than 6 months. The mass was less than 16 ml in volume if solid, or less than 65 ml if at least 25% of the mass was cystic and the disease was limited to adrenal gland. The results of this study showed a 3-year event-free survival rate of 97.7% and 100% overall survival rate, avoiding surgery in around more than 80% of the patients. 6 to 8 weekly monitoring with clinical examination and USG is recommended till resolution or progression, which dictates resection of the mass. Formal staging investigation, bone marrow aspiration or MIBG may be deferred until the age of 3 months, given that there is no increase in lesion size or urinary marker levels. A portion of these patients may convert to stage 4S on follow-up, and they can be managed similar to other patients with 4S. The management for stage 4S as in INCC, INSS or INRG, which is described as MS. Overall survival rate in infants with 4S disease varies from 85 to 92%. In a large cohort of 717 patients, aged 12 to 18 months had worse event-free survival than those less than 12 months. Make an amplification, 11q aberration, NKI index, Floyd-D and LDH. These are independent statistically significant predictors of the event-free survival rate. To treat or not to treat is the question for 4S disease. In asymptomatic patients and patients aged more than 3 months, they can be safely observed and closely followed up till spontaneous aggression. Any evidence of respiratory compromise or organ dysfunction on follow-up, the treatment is to be done as intermediate risk disease. In Philadelphia score is a score that can be used for considering the management in 4S cases. It includes parameters of emesis, respiratory involvement, edema, renal involvement and liver involvement. Each parameter is scored on a score of 0, 1, 2. In newborns, if the score is more than or equal to 1, and in older infants, if it is more than 2, it will need the treatment, which can either be chemotherapy or radiotherapy. In infants less than 3 months, they are better treated rather than observed, because there is a high risk of developing progressive hepatomegaly and respiratory compromise. Chemotherapy is the standard upfront modality. Following carboplatin and the etoposide, if symptoms resolve, we can proceed with observation only. If the symptoms do not resolve, cyclophosphamide and doxorubicin can be given. Resection of the primary tumor does not seem to influence the outcome. Emergent radiotherapy is usually indicated in stage 4S neuroblastoma with respiratory distress due to hepatomegaly and when chemotherapy is ineffective. It is avoided usually for its deleterious long-term adverse effects. Decompressive laparotomy with creation of a cystic pouch is an option in cases of significant hepatomegaly, or there is when respiratory compromise secondary to diaphragmatic elevation or obstruction of the IVC. It avoids the life-threatening events until the shrinkage of the liver is achieved either by spontaneous aggression or by therapy. Coming to the surgical principles of resection, the resectability is determined by the tumor location, mobility, relationship to the major vessels and nerves, ability to control blood supply, presence of distant nets, and overall patient prognosis. The non-adherent intracavitary lymph nodes should be sampled, and there is no indication of random liver biopsies to rule out occult hepatic nets. The two key points when considering surgical resection, which is the fact that neuroblastoma rarely invades the tunica media of the major blood vessels, and dissection is performed in the subadventitial plane. It is usually, as I described, it is done of 3 phases: vessel display of the larger vessels, the vessel clearance, and then the tumor removal. The 5 things that are majorly to be remembered is that it is a vascular kind of surgery. The tumor can be removed piecemeal. The dissection is to be continued from distal to the proximal end. There are 2 parts which are specifically should be dealt with, that is the porta and the pelvis, and the thoracic tumors may extend into the vertebral foramina also. The vascular set during surgery should be ready, and the display of the major vessels is critical. That because of undue torque should be avoided, because of which there can be intimate injury leading to vessel spasm or distal ischemia. The dissection should begin with the lower edge and we should proceed proximally along the aorta, identifying all the major vessels. The site of possible injury should be identified, and the porta and pelvis as said, these are the places where the tumor is difficult to retrieve from. Clearance from vascular structure in thorax is easier as compared to abdomen, but there is an extent into the intervertebral foramina as well that can lead to significant complications. In a right-sided abdominal tumor, transverse supra-umbilical right side and incision can be done. Colon and duodenum is detected immediately. IVC below the limit of the tumor is exposed. The dissection is advanced proximally and the right renal vein is displayed, followed by the renal artery. The vena cava is then cleared from the tumor until the right adrenal vein is reached. Coming to the left side abdominal tumor, left-sided transverse umbilical incision is made. The descending colon is mobilized, and it is best to medialize the spleen and pancreas. The medial dissection along the left radial edge of the aorta is done. The technique is the same. The tissue is divided under tension in length of 1 to 2 centimeters at a time. The dissection moves from what is visible to what is not visible. Is from the distal end to the proximal end. There is also a role of minimal invasive surgery in such cases. The decision is dictated by the comfort and experience of the surgeon. Mostly L1 lesions are amenable, particularly in the thorax. Sometimes L2 can also be resected. Principles of surgery remain the same. Residual disease does not influence the patient outcome or violate the oncological principles. The complications of surgery ranges from 5 to 25%. It is highest with aggressive attempts of removal or complete resection of the tumor. Common problems include operative hemorrhage, adhesions, injury to renal vessels which may lead to renal failure, injury to surrounding structures, neurological deficit such as Horner syndrome in case of thoracic tumors, and nephrectomy while removing the tumor. The survival rates in low-risk cases in a trial of 900 patients with biological favorable neuroblastoma stage 1, 2 and 4S. This trial had a primary goal whether could the localized incompleted resected tumors be cured with surgery alone. The results showed that the 3-year event-free survival rate of 85% and overall survival of 97%. In these stages, INSS stage 1, 2 with MIC amplification, these rates are controversial. In a larger review of 2600 patients, of which 3% had MIC amplification, in those cases which had amplification, 53% had a event-free survival and 72 had an overall survival, which is a significant drop from 98 and 98% respectively. The study actually could not conclude whether a close observation is okay or intensive chemotherapy is further needed. We will discuss the management for intermediate risk. Coming to the management of intermediate risk neuroblastoma, our agenda is classification, non-high-risk group neuroblastoma clinical trials which were prior and current trials that are going on, and treatment modalities that are available. Coming to intermediate risk neuroblastoma, classification as per INRG is L2 group with 11q aberration or poorly differentiated, or M group more than 18 months, which as per COG comes as stage 2A, 2B, which is less than 50% resected. Coming to stage 3, it is age less than 1.5 years with favorable histology or unfavorable histology, or more than 1.5 years with unfavorable histology. Coming to stage 4, it is age less than 1.5 years. The reason why we are discussing this is because this group is highly responsive to chemotherapy. Coming to various classification variables and prognostic factors based on which the classification has been made as age at diagnosis, disease, histology features, presence of life-threatening symptoms as discussed before, and genomic features like MYCN gene amplification, tumor cell ploidy, segmental chromosomal aberrations. Coming to upfront treatment, for low-risk neuroblastoma, as discussed previously, it is mainly observation followed by surgical resection. For intermediate risk neuroblastoma, it is chemotherapy and surgical resection. And for high-risk neuroblastoma, it is dose-intensive chemotherapy, surgical resection, chemotherapy with autologous stem cell transplant, external beam radiation therapy, and immunotherapy. Coming to non-high-risk neuroblastoma therapy, many patients have excellent outcome just with observation. So, need of chemotherapy or surgical resection is minimal. Over the time, the treatment objective has changed its focus to reduction in the treatment intensity, which is done by minimizing short and long-term adverse effects, at the same time maintaining excellent outcomes. The risks that are involved with the treatment are, with surgery it is mainly bleeding, injury to major organ, nerve resection, postoperative IS, wound healing complications, ascites, and at times death. When it comes to chemotherapy, it is myelosuppression, infection to opportunistic organisms, GIT toxicity in the form of vomiting, diarrhea, liver toxicity, drug allergy, fertility issues in the future, and delayed wound healing.
Now, whenever a patient with neuroblastoma comes to us, we have to identify the treatment strategies with optimal survival rates, which has optimal survival rates and minimal toxicity. That is, we have to tailor the chemotherapy according to the patient risk. How do we do it? It is mainly through the clinical trials. Coming to clinical trials, uh, in prior which were conducted prior in intermediate risk neuroblastoma were 5, of which the first we'll discuss in brief about these trials. First is the CCG P81 trial, where the patient cohort was localized unresectable tumor, for which they received 10 cycles of chemotherapy, and they found that overall survival outcome when it came to favorable biology was 100%, and when it came to unfavorable biology for less than 1 year was 93%. Another trial that was conducted, that is COG A361, which was conducted in infants and children more than 1 year group who had localized disease with favorable biology. Here they gave 4 cycles of chemotherapy, which was followed by surgery for children with favorable features. And when it came to unfavorable features, 8 cycles of chemotherapy were given, followed by surgery and radiation therapy if the disease was progressive. Here it was observed that overall survival was 98% when it came to favorable features and 93% when it came to unfavorable features. Thus, we had observed that chemotherapy dose can be reduced, at the same time we can maintain excellent outcomes. Coming to another trials, which was INES, which was INES 1991, which was conducted in 1999 to 2004. The patient cohort was infants with localized unresectable disease. Here they received low dose chemotherapy and surgical resection was done. The overall outcome was 99%. Another trial, that was SIOPN. Here they included children which were more than 12 months who had localized disease and which was unresectable with favorable histology. Here also they reduced the chemotherapy intensity and no radiation was given, and the overall survival rate was 100%. Another trial, that was NB95S and NB97, which involved infants with localized disease who were asymptomatic, and only observation was carried out. Here overall survival rate in terms of spontaneous regression was seen in 47%, and 12% of the patient had stable disease. So coming to another milestone trial, which was ANBL 0531, which was mainly based on biology and response-based algorithm. This further refined the minimal therapy for intermediate risk tumors. The duration of therapy is determined by overall response, and for this, partial response was considered the acceptable endpoint for localized disease, which further signaled reduction in therapy. And biologic prognostic factor, that is allelic status of chromosome 1p and 11q, if were present, there was no dose reduction that was carried out. Here, overall outcomes observed were as follows. When it came to favorable biology, event-free survival was 83% and overall survival was 94%. For localized disease, overall survival was 100%. And for infants, the one with stage M disease and unfavorable biology, event-free survival was 66%. These are the further details of the same study, where they concluded that after 2 to 8 cycles of chemotherapy, response assessment should be done, followed by which surgery should be carried out. When it comes to therapy for relapsed patient, here the children who were first observed or minimally treated, the treatment options that are available after relapse is surgical resection, begin or resume the standard intermediate risk therapy. We can also give second-line chemotherapy trial, radiation or chemoimmunotherapy, or early phase clinical trial if multiple times relapses occur. So, thus we can conclude that ANBL also evaluated a standard salvage therapy regimen for relapsed non-high-risk patients. Coming to current trials that are going on, first is COG ANBL 1232, which has 3 study arms. First study arm or group A is L1 group as per INRG stage. Here the age of the children is less than 12 months, any biology, and other features are the size of the tumor is less than 5 cm in diameter, and confirmation biopsy is needed only if the tumor is non-adrenal. The treatment is only observation without biopsy. Coming to study group 2, or study group B, which is arm 2, here the children that were taken was INRG L2 group, who had favorable biology, age was less than 18 months, and children were asymptomatic. The treatment was just observation. And another study, The study arm 3 or group C included MS as per INRG staging. Here they had further subdivided. If the biology is any, age is less than 3 months, child is symptomatic or there is existing or evolving hepatomegaly, uh, treatment is in response based chemotherapy. If the biology is favorable, age is less than 3 months, the child is asymptomatic without existing or evolving hepatomegaly, the treatment is observed as per clinical scoring system. Again, if the biology is favorable, but the age is 3 to 18 months, child is asymptomatic, we observe. If the child is symptomatic, we go ahead with response-based chemotherapy. If the biology is unfavorable, age is less than 18 months, whether the child is symptomatic or asymptomatic, we go ahead with response-based chemotherapy. Another current trial that is going on is SRK Lines trial, which is mainly for non-high risk group neuroblastoma, where they have classified children into 10 groups. This is the classification which we have further subdivided for simplification. Coming to low risk groups, which involve group 1 to group 6. So low risk group disease stage is L2, age is less than 2 months, and NMIC is not amplified. Coming to this group, group 1 constitutes children with no symptoms and numerical chromosomal aberrations. Here we just observe versus 2 to 6 cycles of chemotherapy as per patient's response. When it comes to group 2, here the children has symptoms and numerical chromosomal aberrations are present. Here we give 2 to 4 cycles of chemotherapy followed by plus or minus surgery. Coming to group 3, where plus or minus symptoms are present with segmental chromosomal aberrations are present, 4 cycles of chemotherapy is given plus or minus surgery. Coming to MS group, where the age is less than 12 months, NMIC amplification is absent. Here, this constitutes of group 4, 5 and 6. Group 4 is the children who has no symptoms and numerical chromosomal aberrations are present. The treatment is mere observation. When it comes to group 5, where symptoms are present, numerical chromosomal aberrations are present, 2 to 4 cycles of chemotherapy is given. And coming to group 6, where symptoms may or may not be present, but segmental chromosomal aberrations are present. Here we give 2 to 4 cycles of chemotherapy plus or minus surgery. Coming to intermediate group, which involves group 7 to group 10, here if the disease stage is L2, age is more than 18 months, NMIC amplification is not present. Group 7 constitutes the one who has differentiated biology. Here 4 cycles of chemotherapy are given plus or minus surgeries. When it comes to group 8, it is poorly differentiated histology, 6 cycles of chemotherapy are given plus or minus surgery and radiation therapy plus or minus isotretinoin is given. When it comes to stage L1, NMIC is amplified, which is group 9 here, 6 cycles of chemotherapy are given, followed by radiation and treatment with isotretinoin. And when it comes to group M, that is age is less than 12 months, NMIC is not amplified, 4 to 8 cycles of chemotherapy are given, followed by surgery. This is the details. When it comes to lines group 7, 4 cycles of chemotherapy, which involves etoposide and carboplatin for 2 cycles. If the tumor responds, we continue with etoposide or carboplatin for next 2 cycles. If there is no response, we go with CADO, that involves cyclophosphamide, adriamycin and vincristine for 2 cycles. After that, we reevaluate for image-defined risk factors. If image-defined risk factors are present, are negative, we go ahead with surgical resection. If they are present, we discuss it with the surgical coordinator for the next plan. When it comes to lines group 8, here as mentioned before, 6 courses of chemotherapy involving etoposide, carboplatin for 2 cycles, CADO for 2 cycles, followed by reevaluation. If the tumor response is present and the image-defined risk factors are negative, we go ahead with surgical resection. But this surgical resection is immediately followed by chemotherapy involving etoposide or carboplatin for 1 cycle or CADO for 1 cycle if there was no response to initial VP and carbo cycle. And if there is no response, we go ahead with 2 cycles of CADO regimen. If there is no response in spite of this and image-defined risk factors persist, surgical resection, decision for surgical resection should be carried out after discussion with the surgical coordinator, which should be followed by 2 more cycles of CADO. If tumor response is present but image-defined risk factor also persists, here we give etoposide, carboplatin for 1 cycle, CADO for 1 cycle, and we reevaluate whether there is response or not. If there is no response, then we go ahead with surgical resection after giving 2 cycles of CAD. Again, if image-defined risk factor persists and they cause no concern, we have to discuss with the surgical coordinator whether surgery should be followed by radiotherapy for 6 courses of 13-cis retinoic acid, and also if the disease is persisting for more than 5 years with undifferentiated or poorly differentiated tumor histology, we have to consider a treatment as per high-risk protocol. Coming to group 9, here these children receive 6 courses of chemotherapy, which constitutes 2 cycles of VP and carbo, 2 cycles of CADO, followed by 1 cycle of VP carbo and CADO, which is followed by surgery, and then radiotherapy, plus 6 courses of 13-cis retinoic acid, that is isotretinoin. Coming to group 10, as mentioned before, 4 to 8 courses of chemotherapy, which involves 2 cycles of PP carbo, then response assessment is done. If metastatic remission is achieved, we go ahead with surgical resection. If metastatic remission is not achieved, we continue CADO for 2 to 4 more courses until metastatic remission is achieved. If there is no metastatic remission achieved, we continue for 2 to 4 more cycles of CADO. And surgical resection is carried out when metastatic remission is achieved and no further chemotherapy is required. Coming to chemotherapy details, they are as follows. When the weight of the child is more than 10 kg, the dose is calculated based on body surface area. If weight is less than 10 kg, it is based on weight of the patients. And when it comes to infants who weigh less than 5 kg, chemotherapy doses needs to be further reduced to 33%. Chemotherapy courses should be given at the indicated intervals, provided absolute neutrophil count is more than equal to 1000 and the platelet count is more than equal to 1 lakh. If the count has not recovered, we can delay the treatment for next week until the counts return back to normal. These are the chemotherapy details, where courses of etoposide and carboplatin are given at 21 days interval, and for CADO, 5 cycles are given, which are again given at 21 days interval, which involves cyclophosphamide, doxorubicin and vincristine. Coming to survival outcomes, it was observed that prolonged disease-free survival in each group, that is low risk group was 95 to 100% and intermediate risk group was more than 90%. Coming to role of surgery for this case, for this patients, surgery is the optimal treatment when it comes to stage 1 and stage 2 disease. When it comes to stage 3 and stage 4 disease, we prefer giving initial chemotherapy and surgical resection is attempted when metastases have been ablated. The goal of the surgery is complete excision of the localized tumor with minimal morbidity. It is also to provide sufficient tissue for histological and biological studies when resection would be hazardous. It is to remove the residual tumor after complete chemotherapy or natural involution of the tumor has occurred, and also accurate intraoperative staging by biopsy of non-adherent lymph nodes. What are the principles of surgery? As Devprabha has previously discussed, it is to limit morbidity as well as mortality. Resection of vital structures, resection around the vital structures is discouraged. We have to avoid removal of major organ, preserve the normal function, control bleeding. Gross resection is acceptable, and lymph nodes which are grossly involved should be removed at the time of definitive tumor resection. Coming to surgery at presentation, here we have categorized patients into 3. A tumor which are suitable for resection at presentation are L1 stage as per INRG definition, which is localized tumor which are image defined risk factor negative. The tumors that are suitable for biopsy only at presentation are L2 as by INRG definition, who has image defined risk factors are positive. Also M and MS tumors with metastatic disease. Also, we have to remember that excision of primary tumor may be an alternative to diagnostic procedure to biopsy when it comes to metastatic tumors, provided the primary tumor is image defined risk factor negative. Tumors which are suitable for observation only are adrenal masses in infants who are less than 90 days of age at presentation. Coming to radiation therapy, when it comes to intermediate risk group, it is given only to symptomatic patients. The target for radiation therapy is both local control as well as control of the refractory metastasis. The tumoricidal doses are 15 to 30 guidates. When it comes to intermediate risk, the patients who receive radiation therapy are the one who are progressing despite surgery and chemotherapy, or the one who have unresectable primary at the end of chemotherapy with unfavorable biological features. And emergent radiation therapy is indicated when ionising stage 4S neuroblastoma is present with respiratory distress due to hepatomegaly, or when the chemotherapy is ineffective. Coming to radiation therapy, most centers prefer giving dose of 10 to 21 gyrates in a daily fraction of 180 to 200 centigyrates. Role of external beam radiation therapy is mainly palliation. When it comes to targeted therapy with MIBG is given in cases of relapse setting. So to summarize, we can say that for low risk disease, surgical resection is done. When the features are favorable, we go ahead with close observation. When it comes to endemic amplification, if complete resection is done, we have to ensure close observation. If incomplete resection is done, we have to treat it as high risk. When it comes to intermediate risk group, chemotherapy should be given, followed by surgery and followed by next cycles of chemotherapy. Radiation therapy is indicated only when the disease is progressive or the disease is unresectable at the end of chemotherapy with unfavorable histology. And when it comes to treatment of 4S disease, if the patient is asymptomatic, we observe. If the patient is symptomatic, emergent medical intervention should be carried out with limited cycles of chemotherapy. Biopsy should be carried out to look for endemic status. If amplification is present, we have to treat it as high risk. If life-threatening complications are present, despite chemotherapy, you have to go for radiation therapy. And when it comes to treatment of paraspinal neuroblastoma, chemotherapy is the